go and look at it and say, hey, I'm wanting to do something on drownings. What are best practices and things like that. It'll also have a list of what has been shown not to work, so we'll also list the ineffective programs so that people aren't out reinventing the wheel and things like that. We've also developed a data kind of summary showing how Texas compares to the rest of the U.S. and the leading injury and violence categories. So you can just go to that and look and see, okay, this is how Texas compares regarding motor vehicle with the U.S. This is how it compares with falls among older adults. We've also compared it with the 5 most populous states, you can see a Texas comparison with California, Florida, Illinois, New York. And then we've also compared Texas with the regional network that CDC has set forth for our region. And that not only includes all the states that are around us that we typically think of as being in our region, like New Mexico, Oklahoma, Arkansas, Louisiana, but CDC has kind of expanded the network to now include, our region includes as far east as Kentucky, North Carolina, South Carolina, and Florida. So we'll be showing how Texas injury and violence rates also compare with those states. And then the final thing that I want to just announce, this was announced in our committee meeting, and we've tried to provide information out on at the front desk all week, is that the Injury Committee is also co-sponsoring with Dell Children's Hospital and TTAF and the Texas Trauma Coordinators Foundation a injury and violence conference that will be held here in Texas June 20th through the 22nd. It starts at noon on the 20th, goes all day on the 21st, and then ends at noon on the 22nd. We're going to be highlighting a lot of national speakers from CDC, from Johns Hopkins, and other, but we're also going to be highlighting some injury programs within the state of Texas. So there's going to be sessions on texting and driving. There's going to be sessions on bullying. There's going to be sessions that show how EMS can get involved in home safety and things like that. So that information is also available we'll make that information available on the GETAC website. It, again, is not too late to register. It's very low cost, $150, and we'd love to see a lot of people there.
And what was that date again? I'm sorry.
It's June 20th through the 22nd. Starts at noon on the 20th and ends at noon on the 22nd. So, any questions?
Shelley, what was the first part of your presentation? Where's that information located, looking at comparison?
We haven't developed it yet. The comparison,
yeah.
That was developed using the CDC Whiskers database, and it was using the years 2003 through 2007, which I believe is the last year of Whiskers. Instead of just doing a one-year comparison, because I live in Oklahoma, and or I lived in Oklahoma, and in 1995, if we looked at violence rates in Oklahoma in 1995 alone, we would show that it was much higher than it normally is, just because of the Burra building bombing. So we like to show at least a five-year year span, and so we picked 2003 through 2007 because 2007 was the last year of data available. But we just developed it, and I'm making that available. I think it's probably still on the computer, so they'll be on the GETAC website. Other questions?
Any other questions? Thank you.
Thank you.
Next, we'll hear from Eric Epley, the Vice Chair, and he's giving a Preparedness Coordinating Council report.
Good morning. The Disaster Committee met on Wednesday from 9 to 10:30. We discussed the STEER, the State of Texas Emergency Assistance Registry, which is the 211 TAR, if you guys remember, the Texas Assistance or Transportation Assistance Registry. That used to be a coastal effort, and that's been taken statewide. There's a group that's been meeting for the last year on that, and so they're rolling that out right now. It's on Chief Kidd's desk for signature. If it's not already signed, it will be signed shortly. And not only on the coast, but throughout Texas, where there are people with functional needs that need assistance that can register ahead of time so that the EMS agencies, fire departments, and emergency management have a list of people if there ever a large-scale evacuation. They know they know their numbers and can do effective planning. The Texas Disaster, did it come up? Good. The Texas Disaster Medical System report, Dr. Kidd gave a report. It's becoming a national model. We've had several state discussions. There's going to be an interstate meeting with Missouri and North Carolina and others sometime in early summer. We're excited about that, to learn from other states, but also see that we're taking some of the things we've learned here and pushing them across the nation. The Emergency Management Conference was very successful. I hope many of you guys attended. If you did, you saw some of the things I'm going to talk about today. One of the most important things, though, is the Texas Disaster Medical System educational modules that we've worked on recently, so that you can take a little bit like ICS 100, 200, 300. You can build on those educational models. Number one, so that people build in a constructive way, but also when they come to your emergency operations center or to a hospital, you can, instead of saying, oh, I've taken some classes, you actually have some level of certification. That's new, and we have 4 modules done. Another 4 to 8 modules are coming over the next years, and those will be both interactive, online, and didactic. I'm going to give you a quick briefing on EMTF. This is a summary of what Victor Wells did in about 20 minutes. I'm going to do it in about 3, so we're going to smoke through this. You guys know about EMTF. One of the new things we're working on, though, is one team, one fight. We're not 8 separate teams fighting each other. We're actually one big team with a lot of regions, with a lot of assets working together to make Texas safer. Go ahead. So the Texas EMS Conference, our Emergency Management Conference, we deployed what looked like an emergency medical task force completely with 5 ambulances and a strike team leader, 2 ambuses, and an MMU. It was the first time people got a visual to see what it actually kind of all looks like put together, and I think that was effective. Again, to the point, those are 2 ambuses, one from one area, one from another, don't even care where, right? The whole purpose is one team, one fight. Go ahead. We rolled out the modules. Oh, by the way, in the middle of the Emergency Management Conference, we did have the Dallas storms and stood up the temporary SOC down in the middle of the conference center. And I think that was exciting because people got to see how it sort of works. I mean, at least on the fly sort of works. And within about 30 minutes, had a full-blown stand-up of the State Operations Center with local partners and the DDCs all in kind of a big area. Go ahead. The cool part was, though, the EMTF coordinators were all there as well doing their work in the booth. And as we started worrying about needing ambulances and ambuses and stuff, those guys were over in the EMTF trailers, writing on the walls of the trailers. All the trailers have dry erase board surfaces. And so they were making their calls, and we stood up about 115 ambulances and ambuses in about 45 minutes. So again, 75 ambulances for the entire Hurricane Ike. In 30 or 45 minutes, we put 115 ready to go for a Dallas tornado. That's the kind of thing I think we're taking resources we've always had and leveraging them and had them in WebEOC ready to be seen. Go ahead. So lots of training and exercise underway. Go ahead. This is a pretty amazing feat. If you guys don't know about the Baton Death March in New Mexico, they have every year. They do it in full-blown military gear. Some of them do it in flip-flops, but it's pretty amazing. And go ahead. These were the numbers from that. EMTF 9 went out there with their trailer. They worked collaboratively with the DMAT and some other people out in the New Mexico area. They had 7,000 runners. They saw almost 700 runners at the end of the race. So it's pretty effective. We did the Fiesta parades. We see about 250,000 downtown in our parades for Fiesta, for Battle of Flowers and Flambeau, and set the full-blown MMU up in that with integration with San Antonio Fire and EMS. Go ahead. And there are other efforts underway. We had Danny and the other guys came. The EMTF coordinators are working more like a team every single time we do these drills, and they're going to each other's drills and learning effectively. Go ahead. This is EMTF 7's drill, and you'll be most interested to see the top slide where there's a drash, there's a Western shelter, and a zoom row all hooked together. Go ahead. So this is a full-scale exercise. They saw 90, I don't remember this number, anybody remember? Like 90 patients, does that sound right, Christine? 93, there we go. And very effective exercise. One of the cool things is this interoperability collar to start hooking different shelters together so that efforts we've bought in the past aren't wasted and put to the wayside. We're leveraging what we have. Go ahead. The upcoming exercises, EMTF 6 has one next week. EMTF, you guys help me. I don't remember the other exercises. Almost all of them are exercising. How about that? The AMBUS program, those 4 exist today. There's another one to be delivered shortly by July. This is what it'll look like. Go ahead, go ahead. So hopefully by late August, you should have 13 of them in the state ready to go, and at least 1 in every region. 2 in most regions in the urban areas and 4 in the Metroplex. If it ever told me, remember, we started this a year and a half ago. Funding-wise, a year and a half ago, we now have all the efforts, all the equipment out there, the ambuses are being delivered. This is a pretty effective way. I hope we just have a storm later in the season if we have one. Yeah.
No.
Go ahead. Go ahead. Statewide strategy group, we have the governance process now is working together. We separated out the executive. In fact, you guys have a motion today to accept this. We're meeting anyway. I hope you accept it because we're doing it. So the Epley way. So this is the governance group that's meeting at an executive level. The guys who have the contracts, the guys who have the requirements to do things go to another. Then the leaders, the operational group. So we have the task force leaders, the managers, and the nurses and doctors who are actually meeting. The MOU is out. All 8 lead EMTFs have signed the MOA. So y'all tell Victor I did that in about 7 times the thing. The RN strike team efforts, I want to thank Denise Rose and the Texas Hospital Association. She has brought together a group of risk management and legal counsel and is working effectively to bring some closure to that. What? Y'all put 3 RN strike teams out during the EMTF 7 exercise. So that project was started to look like it was stagnant, is actually coming to fruition. The other thing I'd like to brief you on is a conference that, while I got the slides up, the American Medical Association co-sponsored a conference with us, go ahead, on a National Health Security Card Conference, 3-day conference in San Antonio about 2 weeks ago on patient smart cards. So what we did was take a Katrina-like scenario, and many of you guys received patients from Katrina, and the frustrations associated with people where you had to completely recreate their entire medical history. So are they demented because of a stroke an hour ago, or are they demented because they've been demented for 10 years? And so the idea that the American Medical Association had was if people carried a National Health Security Card like they carry their, who in the room has their driver's license? Raise your hand. Who in the room has your medical insurance card? Raise your hand. Right? If you had that with you at all times, and your doctor would be the one that updated the information on it. This is not a Google, this is not something that you put your information in as a patient. This is stuff that your provider, that your primary care provider, other doctors and nurses. And so the idea is that they would have 30 fields that would be available and a communications out. This is not a link back to the internet. This is on the card. There would be 30 fields, current meds, medical history, allergies, those kinds of things. The things that they did a study and had emergency medicine doctors and other people participate to develop those 30. We did the drill and used 20 patients. Go ahead. So we developed these portals where the patients would walk up to 4 triage areas, and the 4 buckets that we could put them in was the emergency room, the most expensive, then we had an assisted living / nursing home area, we had a medical shelter, and then we had a gen pop shelter. And the data really showed that the first time around, we did 20 patients through 4 of them. Almost all of them went to the emergency room because you want to do safe than sorry. The second time we did the patients, but we all shifted them over one lane, so they saw different patients, and the medics decreased it from 6 or 8 to the ER. And we put many more in the gen pop, which is good because we're trying to move those people to where if they live every day with functional needs, we want to put them in those locations. So all in all, decreased from 5 minutes to 4 minutes on the triage time, and we used a better utilization to put them in the right places. I thought that was a fantastic drill. This is all concept cards, not ready to go live, but it does show the linkage that I think we need to start thinking of other solutions besides HIEs and all the things working together seamlessly. Go ahead. That's it for that one. We consolidated some agenda items. Dr. Morber's group met and now has, I think, met with Dr. Lakey or is about to meet with Dr. Lakey. About to? Today. So we're excited about that level of commitment. There's an effort to bring the Houston and Dallas groups together and have a collaborative effort with them as well. So exciting things on Mitch's work there on ventilator counts, PD guidelines, informed consent for patients, and they know they're going to be removed from the ventilator at some point, et cetera. And that's it. Wow. Done. 8 seconds.
All right. Now, You were on here, you actually gave both, a report both for the Preparedness Coordinating Council and for your committee, correct?
Yes.
Thank you. Don't walk away, there may be questions for you.
I hate to show my ignorance, but what exactly is the Preparedness Coordinating Council? And I hate to show my ignorance, it's probably been around for 30 years, but I'm just not sure where it fits in.
Great question, and the Preparedness Coordinating Council is actually a legislatively mandated council to our agency. And so it report under our kind of reporting. It's a legislative mandated council that reports to the agency and supports our preparedness program. That's an advisory council. And then technically, I guess if it were to report in, it would report into our DSHS council, which is kind of the equivalent of our board. Great question too. I think I'm going to say right shortly after, probably about 2003 or 4, I think. Right, when after 9/11 and then anthrax issues, and when they started to invest in public health, those type of grant funding, that's when it became. So around that time frame, I think around 2003 or 4.
It's the equivalent of this council.
Yes, it's yes and no. I mean, I think that's the, there's. I think it has its unique point in that it was really designed to make more of a kind of the public health view of recommendations to our agency related to preparedness, disaster response, bioterrorism, and use of those funding and resources.
So I guess my question is what you do, you were able to give 2 reports at the same time. So how are those two, how is our committee
Everything I briefed
different?
you on is what I briefed at the other council. We talked about
Okay.
ETF and those things and the smart card. I gave a briefing on the smart card to
Right.
that group. We also talked about, for instance, our bylaws and our membership. We spent an hour and a half at the Preparedness Coordinating Council talking about membership. I can brief that part as well if you'd like. The Texas Nurses Association, the morticians, Funeral Directors Association had some interest about what their membership person should be. I was trying to skip over some things that you probably didn't want to know, but I briefed everything in here to that group. That's my job as the GETAC rep to the Preparedness Coordinating Council. It's a small group of about 7 or 8 or 9 people.
10, yeah, approximately.
So he did the politically correct thing. I've been on the group for a couple of years, 2 years maybe, and in some ways, I think Dr. Riggins, Chip Riggins now, the public health director for Williamson County, is now the chair, and we're revamping that group and revitalizing it and trying to find where exactly it fits in the mix now as the money and the things change and integrate. It's a little bit of a group without
But
laws.
but it's statutory. Well, I guess that's relative to who's speaking about that. The group obviously is an important advisory council to the agency and to our preparedness programs. Its role and mandated by law, much like GETAC. So it will continue to support us in that capacity. I think the role, as Eric aptly points out, is I think that it is. With Dr. Riggins as the chair, Eric, you're actually the vice chair, I believe, right? What we're trying to model, too, is that linkage of kind of the public health and the healthcare systems piece, and that's what we were trying to do in the leadership there. I think we got to, and we're moving in that direction and trying to better define its role, how it can best support our agency. And just as my aside, my politically correct, but still an opinion, is many of the issues with any of our councils. We have multiple legislatively mandated councils at our agencies, CVD councils, the preparedness council. I've got a handful just in one little section alone, let alone almost every one of the sections has some legislatively mandated councils, so we are required to support them. Now, every session, those councils often get submitted on a list, and the legislators decide whether or not they want to continue to have them, including GETAC, as you know, is put on those lists as well. So, Oh, you may not know that. Well, surprise. Sorry, I hate to tell you, but we're
Sunset,
all
yeah.
put,
Yeah.
we're every,
Sunset, yes,
there's
I know.
usually at least one legislator that always asks and says, what are all your councils and what do they cost us? And we create a giant spreadsheet of all our councils and we submit it and then they make a decision about whether to maintain or not.
Well, and I guess that was my question, how much redundancy is there between that council and our committee? And is there a way to streamline that process? And I'm probably way beyond what we should be talking about, but.
Well, no, I think it's an important question. Certainly, we look for it. I think where we try to stay on the lane, which, you know, you don't hear the discussion is that we do tend to focus more on the public health, on the aspects related to those specific cooperative agreements that are in our shop. And so it is more aligned in that direction. I think where the overlap is clearly, as Eric, you know, in the disaster committee and in our response side of the house. But you know, you're not, I guess what you're not hearing him say is the discussions about, you know, whether we're talking about public health emergency preparedness capabilities or these other more public health focused areas of discussion. But a lot of it does obviously bleed over into disaster response in the committees here.
Any other questions for Eric?
Just one comment. Eric, I got to listen to Victor's complete talk. Pass along our congratulations. The amount of work that they put in on that to get that together, that was just an outstanding, much like Dr. Morberg and all of his hard work. You're doing some really, really great things.
Thank you, I'll pass that along. All the RACs and the coordinators are
Right.
doing exemplary work, and I think Texas is better prepared today than we were 6 or 8 months ago, and certainly more than 2 years ago. We've made light year jumps in the last 2 years.
Yes.
Well, the citizens in Texas appreciate it. Sometimes they're not very nice about sending thank you notes. But
Thank you.
Well, you're not done yet. Come on back. Tried to get out. I want to echo Linda's comments. Having chosen to live in hurricane country, we've come a long way from someone picking up a phone going, hey, can you spare me an ambulance, to a system like this, and it should get national recognition, and many, many kudos to everyone who's been involved in that program. What I'd like to do, if the council doesn't mind, is jump to action item number 2, which has to do with what Eric just talked about, and then we can, in the interest of efficiency. And it's the action item from the Disaster Preparedness Committee, Emergency Medical Task Force, governance documents for final approval and acceptance. And Eric, if you could just explain that a little bit, that may have just explained itself, but just.
Yep, it should be a chart, it's a chart attached as well. So essentially it's that one I showed you. So it shows a collaborative, multi-jurisdictional, multi-disciplinary effort. And we separated the group out into the admin weenies and the ops guys. That's basically what we did. So the bosses all get together and talk about risk and budgets and that kind of stuff. And the ops guys actually do, I like the ops meeting better because we talk about, you know, protocols and formularies and how we're gonna staff the MMUs and what the ambulance programs need to do. So those two groups are meeting collaboratively from all the EMTF regions come together, and we're doing that once a quarter ish. And so that is the governance structure for EMTF. This dawned on me when we couldn't figure out who would approve striping the ambulances, the ambuses the same. I mean, it hit me. We don't have, was the hospital preparedness people in charge of it? Was the GETAC response? Was disaster commit? Who can say finally, yes, this looks like a great design? And so we thought every EMTF being represented at a senior level and at operational level and in a sort of council format in a governance committee structure, if all 8 teams say, yes, I'm the leader of this team and I'm the RAC executive director of this team and I support where we're going, then we're kind of self-governing. I guess that's the way to say it. Within the guidelines and constructs of the contracts, obviously, and with our help and support. In fact, DSHS has almost as many seats on that at the preparedness, at the response and recovery division, at regulatory, and at program and CMU have roles on that governance structure to make sure we're in line and concert with our colleagues. So that's pretty much it. It's working pretty well. We'd love you guys to bless it since we'd like to do it.
Motion. Second.
We have a motion and a second, which would open it to discussion among the council. We do need to work in public comment as we do for for these type of action items. My question is, what exactly are you asking us to endorse? These charts that you gave us?
Yeah, the structure, the membership, that kind of stuff, the concept that you're
Okay.
seeing.
Does that mean any changes in the future would require us to do that as well?
You know, I don't know. It's a good question. How much regulatory authority do you guys want? You know, the MTF governance works with the contract. I think this is we've already blessed this through PCC. We've already blessed it through DSHS leadership. We've already blessed. I'm briefing you because I answer to you as a committee. So I thought I'd bring it to you as well as the other 5 groups I've brought when I was trying to get the ambulance striping approved.
Sounds like really what you're asking for is more of, so we don't have regulatory authority, more of approval or
Support and approval.
Endorsement?
Support, approval,
something
endorsement.
like
I love all those words.
that? Okay, okay.
Interesting that all of us, I had to go get this 5 times from other groups, that support, approval, and endorsement as well. So if we have enough people all saying yes, at some point it becomes a good idea.
Okay, so I'm sorry, who made the motion and what exactly was the motion? Go ahead. Go ahead.
What he said.
What he said.
So the GTAC would support, approve, and endorse the EMTF governance concept as presented.
Right. Okay. All right.
That's what he said. Yeah.
That's what he said.
That's what I heard him say.
Is there anyone in the audience, any public comment on this action item? I'll ask one more time. Is there any public comment on this action item? Seeing none, we're back into council discussion. Any other council discussion?
It's the same statement. I really appreciate all the hard work and effort that's gone into this. Appreciate it very much.
Thanks, Mike.
Any further discussion? All right, then we'll vote on it. All those in favor?
Aye.
All those opposed? Very good. Thank you.
Thanks, sir.
And we'll go back to the front page of the agenda under GTAC Committee Summary Reports, Air Medical Committee, Shirley.
Thank you. And Eric, I would like to also express my congratulations on all the hard work that you guys have done. I think you've done a phenomenal job in such a short period of time. It's truly amazing. Thank you very much for everything you've done.
Pass it along. I'm the show pony. There's a lot of work for us.
I understand. Air Medical Committee met. We had a few items on our agenda to discuss. We did not have any action items, however. Looking at draft rules, approval process, we have still the request to look at the language in our rules to make sure that we are including acute care along with STEMIs and strokes to make sure that we are taking care of all of our patients, that we're meeting the needs of all of those folks. We will, when our draft rules go through the process, make sure that that language is included in there and that we are taking care of all of our patients. Another issue that we've had some discussions on have to do with the EMS ground personnel versus air medical personnel being in the back of an ambulance taking care of a patient, whether you, and typically that involves the fixed wing sector where you've got a crew and a patient that need to get from an airport to a hospital. We have, and the question has to do with basically who is responsible for the care of that patient, and especially, you know, if things go wrong. We have providers that come in the state that are not licensed in the state that are bringing patients in. As long as they're all Texas folks and licensed in Texas, there's not a huge issue. You sort it out. But we do have crews that come in from Florida, from California, from Washington, from all over
They don't come in often enough that there's a need for them to be licensed, but we do have the question on who is actually responsible for that patient in those situations. So we're going to work through that. We put together a work group, and we're going to look at that and see what we can come up with. There is a document, a draft document, model state guidelines for EMS, and hopefully as we get, I think the final draft was sent to the Association of Air Medical Services office just maybe in the last week or so, and we're going to take that draft and compare it with our draft rules and make sure that we are addressing some of these items, and that would include the responsibility of the for the patient when we have those kind of issues. We have done a preliminary comparison of the model state guidelines and our draft rules, and it looks like we are just about 98% on track with what we have already done for our draft rules for changes for air medical. So we'll continue to watch that. When the next draft comes out, we'll go back and look at all of that again. And I think that was the basic, pretty much all of the discussions that we had. Any questions?
Thank you, Shirley. Cardiac Care Committee, Dr. Smalling.
Good morning. We met yesterday at 4 o'clock in the afternoon, and primarily because of a lack of a quorum, most of the business was related to progress reports on 5 initiatives that we'd approved at the previous meeting. The first of those was to attempt to obtain from the RACs their progress in STEMI care organization. Lonnie Den found that the DSHS had done a survey completed in January and has been attempting to see if we could get access to the data. And we heard yesterday that Dr. Kalangis, the epidemiologist at DSHS, might be able to interface with us so that we can begin looking at what's being done statewide. The importance of that is that since we don't have a mandate, state-funded mandate, most of what's been done has been grassroots, and some of the RACs have developed relatively mature STEMI systems. At a meeting last week in Houston at our little conference, we had a STEMI session, and Dr. Mixon presented data on the state of STEMI care in Texas. Dr. Peirce presented his presentation yesterday and at our committee meeting, and hopefully we'll be able to put it on the website for others to see. But one of the maps of the state of Texas looked at the mortality rates per 100,000 population from STEMI across Texas, I think from CDC, but nonetheless, the ranges were broad, ranging from about 40 per 100,000 to over 150. And when one mapped on the mortality data the presence of mature STEMI systems, there was a clear decrement in mortality in areas of the state that had mature STEMI systems. And so we think that this is important in our work trying to facilitate providing materials to other RACs and others interested in STEMI care tools that might help them. Toward that end, a motion had been made to provide video links to the proceedings of the committee so that others who weren't able to attend or who had some interest could access that. And we're working with TTAF now to put a link on the GETAC website to link to the video archives of the meetings. Also, we proposed last time to have a STEMI literature survey produced, and we got approval to produce that and attach it to our website. The idea was to have EMS, EMT, and clinical cardiology articles that people could look at, enjoy, and to get some ideas for improving care in their locales. Additionally, some metropolitan areas have STEMI case reports that are provided by the receiving hospitals or the STEMI centers back to the EMS providers, illustrating the timeline from symptom onset to reperfusion of the artery, what worked, what didn't work, what the outcome was, basically showing the whole team involved with the care of that individual patient, what happened, and potentially areas of improvement or areas of example for others to follow. So we're going to put a repository of those case reports on the website. Dr. Pearce and Catherine Bissell from Houston will be assembling that, and the idea is to have the good, the bad, and the ugly in terms of samples of case reports, so you can see what in this particular situation, what worked and what didn't work, and what could be changed to make things better. Finally, the idea was to look at the success on STEMI treatment from the local RACs and that have mature STEMI systems, and so the plan is to put together groups from the committee that are geographical representatives, in other words, rural, urban, dispersed, however you want to characterize it. What are they doing in STEMI care? How do they get it done? And again, put this information on the web for others to see. Finally, for public comment, most of the comment was from Joel Romo, who's a lobbyist for the AHA, and his report was a little bit discouraging in that, as you've all heard, there are significant cutbacks in terms of bringing STEMI care, acute cardiac care, up to the level where stroke is, and trauma obviously won't happen this biennium. On the other hand, the Action NCDR Registry of STEMI Outcomes reporting on some 80 hospitals that are participating in the registry. These reports could be obtained on a quarterly basis and distributed to the hospitals that are involved in the registry with a minimal amount of support, something on the order of $500 for every 10 hospitals that require reports. So one of the plans was to discuss the possibility of funding $4,000 or $5,000 to provide these reports in the absence of a STEMI registry at the present time. We hope that we could leverage the database that's being developed with private funds to demonstrate to the state that we actually are in the process of developing a STEMI database that could be used statewide, and perhaps down the road the state could assume control of that. So that concludes my report. Any questions?
Any questions for Dr. Smalling? Thank you.
Thank you.
Next, we have the Education Committee. Jody?
Thank you, Mr. Chairman. Good morning, everyone. Education Committee met on April 13th at the Learning Resource Center here in Austin, as well as this Thursday. And we started off by taking a moment of silence to remember DSHS employee Pat Campbell, who you all know died recently, and also John Cook, who was the former fire chief for Denton Fire, also died last Saturday, and the committee paid our respects to them. We had 3 items that we have been working with in the last couple of meetings, and one is to develop a checklist to assist EMS course coordinators in developing the transition courses needed to bridge the gap between Texas EMS courses and the national standards. For those personnel who want to keep their national registry, not required, but just wanted to keep it, we've been working with that, as well as the National Association of EMS Directors transition template to compare the two curriculums and all the certification levels. We also took a look at analysis of the current options for Department of State Health Services recertification at all three levels. For programs who have already been teaching the transition, many of them have been teaching this since 2009. If someone needed that documentation, we will work with DSHS to come up with standard language that can be added to a letter, or for the new personnel, a course completion certificate to denote that they've already received that training. We know that many of the programs started this as soon as it came out. We looked at the templates, and the committee made a motion to accept the transition templates for each certification as the minimum required for transition, as well as the skills, and we took a look at those. We also took a look at recertification options. It's been something that we've had some desire to look at for a while. There's been probably almost seven years now of looking. If you remember, there are 5 ways that EMS personnel can recertify, and that is through taking the test, a research course, National Registry, CE, or CCMP, Comprehensive Clinical Management Program. By no means were we looking to isolate any of them, but we did want to take a look and see which ones were working, which ones people were utilizing and having the most success with. We asked Phil and Terry at DSHS if they could provide that information. Went back to 2009, and in 2009, 9 people took the test to recertify, 41 people used a research course, 594 people used their National Registry current at that time to renew their Texas, and 9,512 people used CE. So it kind of gave us the numbers that we were looking for to figure out which option people were using the most, and no one had used CCMP. In 2010, 7 people chose to test. No one had used CCMP, but 8,495 people had used CEE to recertify. And in 2011, we had 9 people that had taken the test, 23 that had used a research course, 867 people that used their National Registry to renew their Texas, 8,637 people had used CE. So I think when you look at the importance of CE, we're looking at the numbers that people are using to actually recertify, so that for us, we know as educators that the quality of that CE is important, because that seems to be the larger option. Committee looked at CCMP for that last year of 2011 and noticed that no one had used that, and in talking to DSHS has no mechanism really to evaluate CCMP. The committee voted to just make a recommendation to DSHS to do away with, remove it, delete it if no one is using it over a 4-year period. Dudley made a statement to me yesterday at our meeting and asked if we could put that off because there were some ambulance services who might be willing to look at that. And I think that if there are some that are willing to look at it, I'll take executive privilege there and kind of move that off the table for at least another meeting. But it's been on the shelf now for 4 to 5 years, and nobody's touched it and nobody's used it. So it's one of those things that has to be maintained. The program paperwork and proficiency have to be written, looked at. If people are going to use it, great. If they aren't, it's just our thought, and we just wanted to see exactly which way people in Texas were getting their recertification done most often, and it seems through CE and through National Registry. We're also taking a look at CE versus maintenance education. Again, since that was the big number and the big number of people using it, if you've ever tried to take the matrix for Texas and National Registry when it comes to recertification and CE and mesh those together, it's impossible to do. Everyone I know has tried, so we end up morphing courses to try to make that work. So we were actually looking at how could we mirror some of the hours of National Registry, even if that was through the use of card courses. Certainly this is something that we're just taking an initial look at, because if we start to look at card courses versus CE courses, you could probably do most of your CE for National Registry, which you actually can through card courses, But at the same time, if we look as large as Texas is, trying to make sure everyone has the opportunity to be as proficient as they can, the card courses might not cut it all. We might look and, as a group in Texas go, I don't do peds often, so I need some peds. We need some ethics. When you look at most other occupations and professions, they have it broken down into hourly content that are important. So we made a motion to look and try to mirror those in the future as much as possible, but by no means is this done. This is just something that we're starting to take a look at to see if we can meet the needs of our providers as much as we can. Maxie also was at the April 13th meeting and just reminded us that we might have a hard legislative session coming up. Town hall meetings were going well, and looking at the option of looking at some of the transition courses. I had asked Jane Dinsmore to work with me and a couple of other people on designing the transition courses. I know there were a couple of people that asked me, what are they going to be and how will you notify me when they're done? And I said, don't worry, we're not even finished yet. We've just finished the hours that we think need to be there. We will develop the curriculum between now and August and bring it back to this group for them to take a look at. We'll publish it on the website so that we get stakeholder input on making sure that we've covered as much of the transition material as possible. If someone wants to go over the recommended hours, that's great. I can tell you that the number that we've looked at right now for transition for paramedic is only 15 hours over a 4-year period. So we're not looking at something onerous at all. This is just added to CE or 15 hours total if you need that to get your national registry. So we'll take a look at that. We're also taking a look at something that we were asked about, and that was programs sending students out of state for clinicals. We know that there were some programs that were doing it, and we were told that we might want to take a look at that very quickly because of some regulatory functions and some issues. You all might have programs that send students to you. We might have to take a look at that one too, because if something happens, there's a regulatory issue that who is responsible. Is it the state? Is it the student? If it's a basic student, they're not even certified yet. So who has that purview if something happens? They drop a stretcher, they, at the EMT level, or manipulate something incorrectly, or at the medic level, wrong medication, whatever. So we're going to take a look at that and try to help some people with some clinical issues, as well as finding operating room clinicals, which seems to be quite a big deal for us. We also reminded everyone that November 9th through the 14th, EMS conference, been changed. Normally it's the week of Thanksgiving, but just to remind everyone, November 9th through the 14th. And we will have our next work group meeting on July 27th at Blinn College and Bryan College Station from 9 to 3, and we'll get that agenda posted ASAP. That's about all I have. Any questions? Thank you.
Thank you, Jody. EMS Committee, Dudley Waite.
Good morning. Dudley couldn't make it this morning. I believe he's presenting in Atlanta at the STEMI conference. My name is Larry Roscon. I'm an EMS committee member, and I'll be reading you his report. The EMS committee met yesterday, May 10th. We received an update from EMSC regarding recent surveys, upcoming surveys, and available pediatric equipment for agencies that need it. They had some equipment that they were offering to agencies that were not able to purchase these items, neonatal masks and things, BVMs, stuff like that. And so they've got about 50 pieces of equipment still available for these agencies that need it. The committee discussed the rule changes to Chapter 157, and we are monitoring other committees' work until the draft rules come out. The committee named 2 individuals to be added to the joint air medical EMS and medical director work group to address the issues between air medical and ground crews when both are on the scene. This is related to differing certification levels out of state providers and other logistical issues when they arrive on the scene, and one's a higher level of care as far as the ground ambulance being a lower level of care, patient issues that way. The committee briefly reviewed a set of recommendations from the Texas Ambulance Association on new regulations to help address the fraud issues arising in heavier metropolitan area. The committee would like to, if GETAC agrees, begin reviewing these recommendations and working on developing ideas for rule recommendations to bring back to GETAC in the coming months. This is a direct response to the unfavorable media stories out of the Houston area. We also discussed the idea of requiring Texas certified personnel to maintain their national registry in the future, and decided to table that issue until National Registry finishes their CE updates later this year, or unless more issues arise about it. Lastly, we discussed best practices for responding to the current medication shortage issues. DISH's position paper on the website, corresponding pharmacies, and the use of expired medications are all topics being explored all over the state. Agencies that are having or potentially could have issues need to work with their regions and formulate a response and plan. That's the end of the report. Are there any questions?
Any questions?
What is the work group you're talking about, the air medical ground EMS work group? What is their task per se? And the reason I'm asking is I didn't know if we would want a report from that work group to come to the medical directors committee in addition to GETAC.
I believe they're going to be reviewing the rule on the patient care side of the state rule. As far as they're looking at issues as far as PI issues when those crews coming in from out of state turn a patient over, and who's responsible for the care of that patient after they leave, and if there's a negative outcome with that patient, who's responsible, and that's the area that they're going to be looking at.
That's the same work group that I was talking about that we put together in the Air Medical Committee. And we will be sure we include all appropriate stakeholders. We just need to get started first and then identify those.
Any other questions for Larry?
I have one after he finishes.
Thank you very much.
Thank you.
Mr. Chair, I'm sorry, there was something I needed to go back and add, if you'll give me just a moment, to the education. I just looked at it. One of the questions that has come up is that so many times that the education committee, as you all know, we meet between meetings, and it gives us anywhere from 5 to 8 hour days to try to get things done. And so far, it's been rather successful for us. Every now and then, if we have a quorum, we'll make decisions then and not wait and bring it back. And I just need to let everyone know that is not the intent to leave anyone out, not to make the process onerous or tenuous. It's to make the process just the opposite, is that when you have the group there and you've got momentum and we're going forward. I took a recommendation yesterday that we will be, in fact, I've already asked Jory from TTAF to see about cost and to look at possibly video conferencing our meetings that we have as work groups, if we have a quorum and if we're going to make decisions in those. Those are posted 30 days in advance. They do hit the Texas Register. We don't do anything unless we have a quorum. We're not hiding anything. But when those meetings take place, we just usually move forward because of the momentum. But I did want to add that we are going to see if we can get those videotaped.
Thank you for bringing that up. I too had received some concerns about that, and I think that's an excellent issue of topic for when we talk about our strategic plan, how to handle when committees vote and when they meet and who can get access and those kinds of things. So thank you for bringing that up. Medical Directors Committee, Dr. Ellerby, we finally ran him off after many years of great service. We appreciate his service, and Dr. Greenberg has agreed to fill in the role.
Yeah, certainly. Yesterday was the first, or I'm sorry, 2 days ago was the first committee that I chaired. We did thank Dr. Ellerby, gave him a certificate from DSHS. I did that in Chief Riley's absence and expressed our appreciation. He did do it for quite a while. I think he, went running, but he's still on the committee and now he gets to talk. We discussed the various items on our agenda, some of which were discussed at other committees, including the drug shortages, the trauma registry. Some of the other things we did discuss, I think that were unique. We had a fairly significant discussion about revisions or proposed revisions to Texas Medical Board Rule 197, specifically about having the physicians register as being a medical director. Then we discussed why that was important. For our next meeting, we hope to come up with a position statement or a recommendation to come to the council, for the council to endorse. I would actually ask Commissioner Perkins if that will fit their timeline or not. I'll ask her that in a minute. We also discussed an online, there's several online EMS medical director courses coming out. We're waiting to see about one from ACEP that's supposed to be priced correctly. In other words, it's free. And once we see if that is indeed free and if it comes out, we will pretty likely endorse that as a resource for EMS medical directors. On that note, we did approve and endorse a voluntary mentoring and resource program to be placed on the DSH website. That is not on GTEP, the council's agenda for today. I don't know if it needs council approval or not. I can show you what we approved if you would like to see it. I can read it to you as well. It is a list of EMS medical directors willing to provide assistance and mentoring to other EMS medical directors. This would, at the very least, be the members of the Medical Directors Committee with contact information. We would have a link or a copy of the Texas Medical Board Rule 197, some sample protocols, a list of educational meetings, and other resources for the EMS medical director.
I don't think that needs council action. I think if
Okay.
DSHS is agreeable to do that, I think it sounds there's already a list of the directors on there, so you're just adding to it. That would be up to DSHS.
Okay. I think they said it was okay as well. She's looking at me funny. Correct? All right, so we will work on that. I will work on that in the interim and get that up and running, hopefully, and report on the next meeting. And we actually, during our discussions, we learned that there is a DSHS IRB. There's an institutional review board, which no members of the committee were aware of. Sir?
There's actually two.
That is true. There are two. One's
There are two.
there, and they have different.
One for kind of the public health science side and one for mental health, substance abuse issues, yes.
Okay. So the physicians were unaware of that, and that came off of our discussion about the registry and doing research. So we're probably going to dig more into that and possibly ask for a representative or someone who can talk about that at our next meeting. And I believe that concludes my report.
Any questions for Dr. Greenberg? Okay, I'd like to jump to the action items again because there is an action item from the Medical Directors Committee on the agenda. And it's a position paper from the Medical Directors Committee. Hospitals should share quality assurance data, including patient outcomes, for the purpose of quality improvements with EMS firms. And I believe there's in our packets, there's actually that statement. Would you like to explain that a little further?
Thank you. We discussed this at the February meeting, discussed and approved this at the February meeting. This, I believe, came from the Houston area, and we massaged it somewhat, tried to shorten it somewhat, so that it would apply to the entire state. It is available on the website as one of the notices from this meeting, and we approved it at the medical director committee before. Basically, this is to empower EMS services to give to hospitals to say that it is entirely appropriate and not a HIPAA violation to share information about patients which were transported by that service. And I won't read it the entire length, but I'll open for questions if there are any. And I would move for approval if I can so do.
Okay, we have a motion. Do we have a second? We have a second. All right. Is there any council discussion? And as I interpret this, just for clarification, you use the word should, so this is not a requirement, but it's a strong please. Okay, very good. All right. Is there, on this action item, I'll open it for public comment. Would anyone like to comment on action item number 3 on the agenda? I'll ask one more time, is there any public comment on action item number 3? Seeing none, I'll close public comment time and go back into council discussion. Is there any further discussion from council?
There we go. I just, in contemplating what you guys are trying to do, I applaud it, but so is this letter necessary for those outside of recognized trauma facilities that don't already have that PI conversation taking place? Or what's the situation where this letter may exact change, desirable change, that we couldn't possibly look at doing some sort of a rule to kind of mandate that exchange?
Did you want to speak, Kathy? No. All of the rules already exist that allow this. It's just when it comes down operationally, a member from an EMS service contacts a hospital and says, hey, can you give us some update on our patient we brought in? They say, no, we can't do that. That's a HIPAA violation. You're not allowed to have that information, even though it is written in the rule, even HIPAA, actually HIPAA specifically says you're supposed to share that information. This is more of a common sense, plain English approach where somebody can say comes from GETAC and DSHS and says, absolutely, you're covered to provide this information.
I just wanted to make sure that it wasn't room for improvement with some sort of a rulemaking process.
We actually, I've talked about this before, we actually have a very strong, one of the strongest laws in the country in regards to PI, confidentiality of PI documents for our RACs, for our EMS providers, and we are actually the envy of some other states that we have such a strong one. So we don't really need rules. We have it. It's a matter of helping to have people out there understand that we have that.
Is it possible that I hear the term for hospitals that they must participate in their RAC? Is it a stretch to say that participation includes sharing data with their EMS? And if they don't, then they're not participating?
Participations, we fairly much leave defined by the RAC.
By the RAC.
But I will tell you that hospitals that aren't participating in our emergency healthcare system in some way, trauma designation, stroke designation, coming on the STEMI system, and there are hospitals like that, and they're not interested in, there's really no, I can't take their license away if they don't, okay? So there's really no, right now, for a hospital that's not in some way, even though if they take ambulances, they're participating in the emergency healthcare system, but there's no, I have no way. I can do it, you say to a hospital that wants to be designated, you have to participate on the RAC. I can say that about stroke, but because that's over and above, but I can't take away a hospital's license for not participating on a RAC. Does that make sense?
If we already have the rule that they have to share, how will this help?
I think the way this helps is it's more readable rather than sending somebody to the rule and have them first of all, try to find it. This is, again, it's more in plain English. It's something
Okay.
that the paramedic or the nurse or the EMT can send to the hospital and say, look, this is it in plain language. Again, the rule is there, but it's like all rules. When you try to read it, it's cumbersome.
Okay.
And this actually refers to the specific rule.
I noticed it did, so I
So,
was curious. All
Yeah,
right, thank you.
This is more to put it at the level of the provider and the clerk or the nurse at the hospital that's, it doesn't even know that these rules exist truly.
I
except-
would agree with Dr. Greenberg. I mean, and what we do is we provide the stamp of approval on this whole process so that people can be assured that the reference language is specific to the rule. It not only stipulates what the rule is, and as long as you operate within those parameters, you're in good shape, because oftentimes the legal language that this stuff is written in can be confusing, it can be misconstrued. And so this helps define the spirit of what that language is supposed to talk about.
Wonderful, thank you.
Any other comments or discussion on the motion?
I just want to say real quickly that I think, at the provider level, that can be very helpful. It is difficult sometimes to get that information that you need for PI purposes, and so I really do think, hope that this will be some information that we can give those folks that say, oh, no, we can't do that, and help the providers get that information.
Any other discussion or comments? Seeing none, all those in favor say aye. Aye. Any opposed? Motion passes. Dr. Greenberg, did you say there was something that may need to go on the agenda for next time? Or you weren't sure?
For next time from the medical directors will be, we hope to come up with recommendations and language for Texas Medical Board Rule 197 for action by the council.
I'm getting the wave.
I think you're going to be past the timeframes on the
yeah.
medical board by then.
Yeah, that's-
So I think if you want to give input, you're going to need to do it directly to the medical board in the next month or so.
And we can only do that as individuals, correct?
Yes.
Okay, not a problem.
Okay.
Can we put it on the agenda just in case? Because it's possible that, I will tell you, what I send to the medical board will actually ask them if they can delay past August for when
Okay.
GETAC could meet. I'm sure that won't be successful, but I'll ask it.
Okay. Well, that's going to be a mixed message for them because we had asked them to move expeditiously.
Okay,
So I don't know how they'll react to it.
okay.
But yes, we can, we don't do up the agendas until, a month before? 45 days before. So yes, we'll put it on our list.
Okay, because I know this is supposed to go to the Texas Medical Board on their June 7th meeting, and then it has to go out for public comment
For
from there.
30 days.
And then
yes.
I don't know when their next meeting is
Okay.
after that.
So the timing, yeah, okay.
It's close, and that's.
It's very close.
I would just hate to miss our opportunity to take action on it because it wasn't on the agenda.
Okay, all right.
All right, thank you. The next item we'll cover is the Pediatric Committee with Dr. Macias.
Thank you. Pediatric Committee met yesterday. We started with an EMSC state partnership update. There were 5 critical points. The survey for the National Pediatric Readiness for Hospitals, which was done in 2001 initially, is being revised with a significant resource from the National EMSC office. What's different about this survey is rather than simply be a survey, it will be linked to quality improvement strategies and best practices. So there'll be opportunities for hospitals when they receive a readiness score to look at strategies for how to improve their pediatric readiness. The Essential Pediatric Airway Project has continued so far. The state partnership has distributed 220 neonatal BVMs and 100 entitled CO2s. There's still a number of those available, so any agency simply needs to contact Tony to receive those for free. Nobody has been refused any of those. The pediatric continuing education program is expanding into rural area education with strategy for looking at adjunct funding from flex grants. And then in our subsequent meeting, because of time constraints, both an update on the 3 evidence-based funded projects. These are evidence-based pre-hospital protocols for pediatrics, as well as a full description of the online-offline state survey will be presented at our next meeting. 2 other issues of importance. One of them was we had told this committee we would come back with caveats for the definition of pediatrics. It was our understanding that it was the trauma committee's intent to make that definition parallel to that of the American College of Surgeons definition. So there was actually a discordance in what is printed in the prior version and today, and I think the trauma committee's after us, so they'll have an opportunity to chime in on that. But we did want to offer a caveat. Because we felt that developmentally children at different ages represent different physiologic entities, we were cautious that a single definition would be applied uniformly in all situations. So we endorsed the general concept of age less than the 15th birthday as the pediatric definition for statistical purposes. For regulatory measures, clinical care recommendations, and educational initiatives, we urge that age cutoffs for defining pediatrics not be so restrictive as to disregard differences in development, physiologic, emotional, and sociological, and such differences should be taken into consideration with programming and metrics so as to account for expected variations in these populations. So we'd like that caveat to be added and ask your endorsement for that definition and the correction of the age. The other item that was of import, I briefly described a strategy that we would take to offer position paper on minimizing ionizing CT radiation. You'll remember the importance of this is that public health data suggests that for every 600,000 abdominal CTs that are done, that probably leads to an attributable number of 500 pediatric cancer deaths. So strategies like Image Gently and ALARA that look to minimizing ionizing radiation, more commonly done in emergent care settings for children, especially for trauma, have taken a very strong win nationally. We have developed the following 5 recommendations that we will put in a position paper, but we wanted to vet these recommendations because when we bring forth the position paper for the next meeting in its entirety, we wanted to make sure we had adequate public vetting of all these concepts. The 5 concepts are: 1, that all CT scans on children should be performed using pediatric dose reduction protocols. Number 2, that imaging modalities that do not use ionizing radiation should be used when feasible, example being ultrasound for evaluating appendicitis. Number 3, the avoidance of the use of protocols which automatically result in the performance of multiple CT scans like head, cervical spine, chest, abdomen, pelvis in pediatric trauma patients. Number 4, that providers avoid further CT imaging once a decision to transfer to definitive care is made, unless the accepting institution specifically requests a scan prior to transfer. And number 5, that the accepting institution should avoid repeating scans, that they should consider access to life image or similar cloud-based translators that will allow the translation of those images. So we'll bring back those 5 recommendations within a position statement, but we wanted everyone to have the opportunity to consider that and offer us feedback prior to that next session. Any questions?
Any questions? On the, going back to the language, you were discussing pediatric. I think what I heard you say was for statistical purposes, it's going to be anyone less than 15 years of age.
It's less than the 15th birthday.
Less than the 15th birthday. And that, but when you're treating, you take into account their development and things like that. Is that something that needs to go in rule?
I don't know.
No? Not in 157?
I don't think so.
No.
Jane?
No? Okay.
I wouldn't recommend it. I mean, I think you're going to narrow your scope too much. You're going to paint yourself into a corner here from a clinical care delivery standpoint. And people are going to get, instead of enhancing access to pediatric care, we may have people backing away from. Do I need to repeat that? Okay, so I would recommend against that because if the rule becomes too specific, you're going to paint yourself into a corner. It'll impact healthcare delivery directly and actually may inhibit participation in pediatric healthcare, particularly in trauma patients, for example.
Okay, thank you.
So we did in fact want to prevent the overprescription of the way that that definition was used, but we wanted to endorse that we move towards a standardization similar to what the trauma committee said.
Okay, I just want to make sure, are you modifying existing position paper, or is this one that's going to come out?
So I believe this committee endorsed the definition that trauma offered. We'd like to revise that. It was, I think, inaccurately listed in the minutes from the last session, as I believe it said through the what was implied in the way that it was stated was that it was less than the 16th birthday, which is not consistent with the American College of Surgeons. So we would like to change that definition and then add the caveat for how it's applied.
Okay.
But not to rule.
Not true. Okay. And then you gave the, you said you're going to prepare, I'm trying to make sure I get stuff for the next agenda because I'm notorious for
Absolutely.
forgetting to leave that on. So, but then you're also going to have a position paper you'll develop between now and our next meeting.
Right. It
on
has
our
those
agenda.
recommendations.
It has those 5 recommendations.
Yes, it has those
Okay.
5 recommendations. We'll distribute it for this group to vet, for our group to vet. That way we can ask for an endorsement at the next meeting.
Okay. Thank you.
Thank you.
And I would recommend too on the, can you read the first recommendation you had about, because it sounded rather restrictive as well. And I think that's the same as writing a rule.
This is for the CT radiation or
Correct.
for the definition of pediatrics?
No, for the CT radiation.
That all CT scans on children should be performed
Should,
using
okay.
pediatric dose reduction protocols.
One other question on that. When you do come up with your final recommendations, particularly on imaging and sharing data, it would be helpful to identify programs that would be optimal so that institutions don't have to go through this whole process. You know, we are a large state. There really is no healthcare system. It's a hodgepodge of databases that we begin to share. And if we can have something that can link those databases and you know from your research that it's probably the optimal systems, then I think that recommendation, here are things that might be able to facilitate this data
We know of
transfer.
at least 2 institutions in the state that have already adopted the life image that allows that translation. We were careful to avoid proprietary language, so we're offering an alternate of cloud-based translator programs, but we'll list options.
Yeah, there was significant discussion about that yesterday,
Yeah.
and it sounded like they're working. Sounds like the systems
Yes.
are working. So even though they're proprietary, it would be nice to have that resource available.
Yeah, I agree.
Thank you.
Thank you, Dr. Macias. Next, we will hear Trauma Systems Committee. Jory?
Committee Chair, committee members, thank you very much for the opportunity to be here. Russell, do you have the PowerPoint? The Trauma Systems Committee has met multiple times since we met in February. We met on April the 17th specifically to look at the waiver issues. Then we met again on May 7th specifically to look at the registry issues, and then we did have our meeting on May the 9th. And so we have a PowerPoint presentation to show you as a result of that, with the recommendations from the committee regarding the trauma center criteria. So first, I'd just like to address the pediatric issue. So their language should say, and this is what we were thinking the language said, is 14 to 364 is the pediatric age. Once they hit their 15th birthday, then they are the adult. Okay. We're going to walk you through some of our recommendations. So the first thing we looked at is we had to find trauma center performance standards. And so again, these will be published and we're moving them forward, but one of the recommendation changes with the hospitals will have systems in place to activate the trauma team in compliance with current accepted guidelines based on information received from the field EMS agency. So it's just a clarification. And then number 8, the patient quality, we had put in there that the Joint Commission safety goals be incorporated into the hospital's performance improvement process. And so because some hospitals don't use Joint Commission, the change was patient quality safety goals. And number 12, some of the recommendations. And so what happened was this was reviewed in the February meeting, and then we asked the Trauma Coordinators Forum and a group to specifically look at this. And so these recommendations were from them, and they were adopted and approved by the Trauma Systems Committee on the 9th. So number 12 says that the trauma patient with multisystem injuries experiencing high energy mechanism of injury, or with injuries that are threatening to life or limb, are admitted and managed by the trauma surgeon or surgical specialty service. Number 20, the trauma center medical director and trauma program manager participate in hospital, community, and regional emergency management response. This is a tighter language than what we've had in the past. And then under the PI events, number 8, there was a modification. We had said that patients delayed movement to the OR stat cases. We defined that stat case to a hemodynamically unstable patient and our patients with injuries posing as immediate threat to life or limb. And then finally, number 23, the trauma patient transferred to a non-designated facility. And so again, on the PI events, number 14, oh, that's backwards. So the other question that we had, and we asked Dr. Daniels and Marjorie Ligas, and again with the TTAF group under the trauma division, to look at the language specifically to the trauma center physician, those that are not board certified, that are in the core group of physicians, trauma surgeons, or those that are in the specialty service. And so these are the recommendations from Dr. Daniel, an alternate pathway for the level 3 from the surgeon. And so the first thing is that the trauma medical director would have to put a letter in their file approving their participation in the trauma call panel. In addition to that, they have to have ATLS and 27 hours of trauma CME over 3 years and attendance of 50% of the meetings. For the emergency physician, again, the letter by the trauma medical director based on reviewing the performance in the medical records of the trauma patients, and again, documentation of a current ATLS, 27 hours of CME over a 3-year period, and then review of PI issues. And then for the orthopedic surgeon, the language you can see is the same for the emergency physician, and then same for the neurosurgeon. So in other words, the trauma medical director would have the authority to say that this physician, based on their experience and their competence and past experience and review of the PI, we approve that this individual be on the trauma call panel in addition to the 27 hours of continuing medical education, as well as the current ATLS with the exception of the orthopedic surgeon and the neurosurgeon. We spent a lot of time in the February meeting regarding the trauma registry validation. What we identified in some of the data that we've pulled out of the registry is that hospitals are sending data, they're getting feedback that there's problems with their data, empty data sets or incomplete data sets, and they're not fixing that. So we want to tighten the language on the trauma centers in to make sure that the trauma centers, once they receive, either there's a warning or an error, that they are held accountable to address that. And so we're asking for a 30-day timeline for the hospitals to correct that and send it back to the state. The Texas Trauma Registry, again, with the meeting from the 7th, there was a significant amount of discussion about the development of the registry. And so one of the issues Mary Frost brought up is that there needs to be a data dictionary for the registry. This has been discussed in multiple committees, and again, these data elements need to be clearly defined so that we had good consistent data. And again, the data dictionary, I won't walk you through every line on the slide, but the data dictionary is used as the foundation for data extraction and data entry into the registry. This is just an example. This is from the National Trauma Data Bank. From vendor communication, many hospitals are preparing their budgets, so there's a lot of questions from the hospitals to the vendors. What can we expect as far as budget change? We needed that information by the end of April to make good budget decisions for the hospital. Reports, there was a question about to define which reports can be generated. To prepare for the meeting on the 7th, there was an email that was sent to all the trauma centers asking them to bring potential reports so that they could share that with the vendors. Education, again, the the individuals inputting the data needed understanding the education, and again, we go back to the data dictionary. So it led to these series of critical questions. The first question is, if the stakeholders pulled out of the development, can the vendor develop a product that can support accurate AIS scoring and ISS scoring and PI infrastructure that is in line with the national standards? This is a critical question because right now the stakeholders are adding a lot to this registry development. Those stakeholders, if they're not here in 2 years or 3 years, will this be a sustainable registry? In addition to that, does the vendor intend to bid on other trauma registries or any other agency or any other state? There's a lot of questions regarding that because the stakeholders are helping develop this registry. So if they're going to sell that registry someplace else, the stakeholders want to know about that. Other critical questions. The first question is it time for the registry to try to move away from developing a registry that can be used by the trauma center with their PI and their data collection and move into a data repository, very much like the National Trauma Data Bank, so that we can use it to analyze the data and make decisions. So other questions are, what's the timeline for DISH to hire appropriate personnel to manage the registry? Who is dedicated to the trauma registry? How many staff? How many FTEs? And if they're an educated person on the registry work group that's hired by the state that looks at the AIS and ISS scoring. And what about the hospitals that are not currently participating in the designation process? There is a law that says they're also required to participate. And then another critical question is, when is Texas going to join the National Trauma Data Bank and be part of that process? So this is the reason it was brought up, is these are the number of trauma centers that are currently providing data into the trauma registry. So there's a lot of questions on that. We're sending a lot of data in, but again, we would like to have good data, quality data, so that we can make decisions. So the other thing we looked at are trauma center site surveys. We saw that there's an issue with PI. And so one of the recommendations is to standardize the PI language to meet the changes at the national level with the ACS. And so again, this was passed, so the goal is to move into the word event, define what type of event it was, where this event occurred, which is called the domain, and then to move away from the word judgment and move into the word determination, and then use preventative measures instead of action plans. From the deaths, again, we have historically classified all deaths as non-preventable, preventable, and potentially preventable, and the American College of Surgeons is moving away from that language. They started this process 2 years ago, so we wanted to move Texas forward with that. And so the terminology will change from non-preventable to mortality without opportunity, and potentially preventable and preventable will turn into the terminology of mortality with opportunity. And so we'd like to separate those two and call them mortality with trauma center opportunity and mortality with regional system opportunities. So again, these are the hospitals that were participating. So the waiver, these were the discussion of the waiver. If you guys know that there's an innovative opportunity, the innovative projects. And so these were the recommendations from the Trauma Systems Committee, is to look at a statewide PI plan. We do have a PI plan. We'd like to use some of that innovation to actually activate that, and that is an EMS and trauma center plan. And then develop the state EMS hospital surge plan specifically to look at pediatric trauma burn needs capabilities, to expand, to look at the opportunity for pediatric categorization. Again, one innovation is to look at the trauma registry. Again, geriatric care, the patient experience, and then expand rural care and develop incentives to keep the EMS providers, physicians, and nurses in the rural area. And then the last one is to look at injury prevention activities. And so that's the committee report from the Trauma Systems Committee. We did pass all of the issues regarding the PI issues as well as the change in the terminology for closing of the PI issues from the Trauma Systems Committee. Can I entertain any questions?
Go ahead. Hey, Jory. I assume that the trauma director option is from the ACS COT language that
It's a
already
little
exists.
different. It's a little different because in the, if you know, there's a critical pathway that the physician can go through, an alternate pathway. That's extremely complicated, and so Dr. Daniels and his group broke it down and separated it out and came up with language I think that is very doable.
My question is, since the ACS participates in our designation process, is this going to conflict with some of those reviewers if it isn't exactly like theirs, or at least that's my only issue with that. I mean, would that create a problem with the ACS review team?
It would only create a problem if a level 3 trauma facility in the state of Texas chose to go through an ACS survey, because this is specifically language for the level 3 trauma
Gotcha.
facilities.
Okay. The other question I had is on item 12 that you had up there, talking about life threat and limb threat patient categories that should be admitted to the trauma surgeon and/or surgical subspecialty.
Yes.
My feeling is that if on the surgical subspecialty should be trauma paneled surgical subspecialty, I think that would be something that could be misconstrued on level 2s and level 1, because you could have surgeons there that are not part of the trauma panel.
Right.
And we need to know that if they do, say a patient chooses to use that surgeon, that should be a default fallout that we can monitor and quantify. So
So your recommendation is to change that to the trauma panel?
yeah, a trauma panel surgical subspecialist.
Sure.
But that way it keeps it all within the trauma registry, and if it doesn't fall into that trauma panel, it's an automatic default.
Right, I agree. We'll add that. Any other questions from the committee?
On the very first slide, you changed number 8, and I think it was it patient safety?
Yes, sir.
And you said some use Joint Commission and some don't.
Right, some of the critical access hospitals and other hospitals in the state of Texas do not go through Joint Commission review.
Okay.
So we had specifically said Joint Commission patient safety goals. Let's see if I can find that.
There it is down there.
Right, so it originally read Joint Commission safety goals and never events are integrated into performance standards. And so because of the fact that not all hospitals in Texas do go through Joint Commission, the recommendation is that patient quality and safety goals are integrated into the performance standards. So the safety goals are still there.
Okay, so my question though is what is the standard? Is it just left up to the hospitals then?
Well, there's national standards that are published, and so that's what we would be looking at.
Okay.
Those, if you're familiar with it, it's patient identification, handoff, timeout, hand washing, all of those issues. And certainly we're not saying that you have to integrate every single one of those, but the hospital should integrate those into their PI process.
Okay, thank you.
Right. That's the reason we wanted to leave it like that.
Yeah, there's now another organization out there doing what the Joint Commission does, so I agree, making it generics better.
One other question, Jory, once this passes, will this be on the GETAC webpage so that trauma coordinators can look this up? And
Yes, so the process is we're still in the rule phase, so it goes back to Kathy and Jane and her team, and they will look at it. And remember, we're making recommendations. They really write the rules. So we expect that to come out in early 13 to be able to be implemented. Right, no, just out. At the same time, the American College of Surgeons is changing the Green Book. And so the Green Book, the goal for the Green Book, and much of this language will match the development of the new book. And so that book is due out in early January, and then any hospital that would be seeking trauma center verification by the ACS after July would be held accountable to the new standards. And so many of this is going to be the same.
There were some slides that you put up there that were lots of questions about the registry.
Yes, sir.
Were those questions to be answered, or did they get answered already?
No, they're still open. The meeting on the 7th, we had a very good discussion with the vendor group and Tammy was very gracious to stay with us for about an hour and a half and answer questions. And so the registry, the trauma centers and many of the EMS providers that were present, that's a series of questions that they have continued to send in. And so we would like for it to go through GETAC and then have the vendors to be able to have an opportunity to answer those questions.
So I guess a better question is, was there something you need the council to do with those questions, or are you, as a committee, getting those answered through your normal meetings?
They're looking at me. That's it. What does that mean? No, so I think what I was just asking is that as long as we get those questions forwarded so that we can begin to look at them and see what, responses would be required, we can do that. So, absolutely.
That concludes your entire report?
Yes, sir, it does.
Any other questions for Jory? Okay, we do have an action item on here. Action item number 4, we'll jump on the agenda to that. This is from the Trauma System Committee, and that is to support the committee action to increase driving while intoxicated, DWI prevention. So let us know exactly how we can help you.
I think the request came from two meetings ago, and it was specifically to ask for GETAC and for the state to give us some guidelines on what committees or what infrastructure at the state actually is out there that's looking at DWIs. So we know what GETAC is doing, what the Trauma Systems Committee is doing, what the Injury Prevention Committee is doing, but are there other committees, organizations in the state, for example, from the law enforcement, other state initiatives that we could collaborate, partner with to make the impact of DWIs more known? I mean, Texas continues to be number 1 or number 2 from fatalities related to DWIs. And so if there's an opportunity for the healthcare side to partner with the legal, the law enforcement systems, we would welcome that opportunity.
So then perhaps you're looking for us to, and I'm not putting words in your mouth, help me out here, to endorse the trauma committee's attempt to contact other state agencies and work with them?
Yes, we would like that, but we would also like for you to help us identify them. So we're doing searches, but maybe you guys know of other organizations that we don't know.
Okay. For us to take action on this item, I'll need a motion from the council. Dr. Fernandez, a second? Second. Mike? Right, we have a motion and a second, so we open for council discussion. And again, I'm not really clear what the exact motion is.
So here's the motion, as I understand it, and jump in here if I get this wrong. So the motion is to have the GETAC Council help TTAF identify state agencies who have similar missions as it relates to DWI and motor vehicle accidents in the state of Texas. So that's one part of the motion. The second part of the motion is to assist in supporting relationship building between TTAF and those agencies once they're identified.
That's correct.
Okay, is that
good? Right, any council discussion? I'll open it for public comment, action item number 4. Any comments from the public? Going once. Anyone else wishing to comment on action item number 4 from the public? No comment from the public. I'll close public comment time and go back to council where we can discuss it further or vote on it.
vote?
Okay. All those in favor of the motion, say aye.
Aye.
All opposed? Motion passes. Thank you, Jordan.
Thank you.
Next, we have GTAC Liaison Summary Reports. TTAF, Dinah Welsh. And I'm going to say it every time you come up to talk, that how much everyone really appreciates TTAF broadcasting these meetings. It helps a lot of people with travel expenses.
Thank you. We are glad to do it. The only problem with watching the web stream is that I'm a little nervous about standing here. I stand real skinny. If you've watched at all on the webcam, this camera back here, it looks like you're looking through a peephole, so you know how that looks, sort of. But I so appreciate Jason and Russell and their work. I know they quietly sit back here. Very interesting. Each time we've done this, we've learned something. We prepare, like y'all do in all of your jobs, for the next time. And so this time we had everything ready to go, good to go. Wednesday morning, flip the switch to start webcasting, and Ustream that we use for the webcasting is down. And we're scrambling, trying to figure out what's going on, thinking it's the hotel, it's something. Well, it ends up, and you can't make this stuff up, the Russians have brought down Ustream. There's a little bit of political unrest, and who knew that TTAF and GETAC would be involved somehow with the political unrest in Russia, but we were. So we don't expect that every time. We'll try to work through that for the next meeting. But in all seriousness, for those of you that were trying to watch one of the meetings on Wednesday, we were able to record those. They are archived, so you can go back and see them. And that's just sort of a reminder that all of these meetings, you can view them live or you can go back and watch them later to make sure if something was said correctly or just make sure you understood it. We also will look at working with the various committees that I know meet outside of GETAC about trying to do some kind of webcasting. It will not take on this effect. This is pretty time and labor intensive, but I think there are ways that we can work at that and get, Jody, I know you were talking about education committee meetings, that we could work with y'all in trying to figure out a low-cost solution to that. And then we'll obviously work with the state to make sure that that all passes muster. What I've just passed around to y'all is the Guide to Trauma Center Designation for Hospital Executives. This is a publication that TTAF's Trauma Division had worked on for quite some time. Lisa Price, who chairs our Trauma Division, she and her division did an incredible job putting this together. Ann Ward, who helps us with communications, she made it actually look very, very professional, and we're very proud of this. This went to the hospital executives to try and explain to them what trauma coordinators do every day and fight for every day, and how important the trauma system is to the healthcare system in Texas. We'll be sharing this with legislators, as well as other key audiences, but I just thought y'all would be interested in what we are doing, what we've worked on. We'll be working with other divisions within TTAF to come up with, I hate to say similar, but just look at different opportunities that might be out there for additional publications to increase education of what GETAC, TTAF, what we all do every day. We are celebrating, like everybody, Trauma Awareness Month, as well as National EMS Week is later this month, May 20th through the 26th. And it's Nurse Week and CVD Awareness Week. So if you're not very aware in May, you're just not paying attention. There's a lot to get out there and make sure that people are familiar with the issues that are all near and dear to our heart. We have talked about TTAF and our involvement now in seeking out grants that will help to further develop trauma, emergency health care, and acute care in Texas. TTAF did apply for the HHSC Healthcare Innovation Challenge grant. The good news is we are still in the running. The bad news is that they released the first 26 awardees on Tuesday. We were not one of those, but that was just a little over 11% of the total dollars that they have to distribute. So again, we still haven't gotten a no. So I was hoping that I was going to be able to uncross my fingers and toes and everything, but they will continue to cramp up a little bit from being very wishful for that. TTAF has also been involved in a number of interim studies with the budget, and there was a hearing not too long ago about the registries. We'll continue to monitor those and be involved. And just I wanted to point out just a few things. Additionally, TTAF has coming up, there is a data management course that's going to take place September 14th in Conroe. There's information on the TTAF website on that. As well as we will be doing a stroke symposium again this year, October 12th, and that's going to be held in Lubbock. We're also really excited. Y'all probably recall Dr. Rock. He is now our EMS division chair, and with his division within TTAF, we're going to be rolling out some monthly EMS lunch and learn webcasts. And those should start in September. His division, they've come up with a list of 12 different topics and going to get experts on that to sit down for an hour, Everybody can sit around the computer and view, and then there will be some interaction as well with those presenters. And so those should be rolling out in September. We're really excited about that and his energy. Happy to answer any questions. We appreciate what y'all do.
Any questions for Dinah?
Is this available in PDF on the website, or?
It
can
is
we get
not. It is not yet. It will be eventually. I can get you additional copies. There's a form online to order additional copies, so we can get those to you, and it will be available PDF eventually, but it hasn't been made available yet.
Anyone else? And I guess we'll say thank you and das vidanya.
Thank you.
All right, as this meeting is, I didn't swear at her, by the way, I said goodbye. As this meeting is going to go on lengthy, we may have some members that want to make public comment, and we'd like to go ahead and open it for that general public comment at this time, in case people have to leave.
Hello, my name is G.K. Sprinkle, and this comment is really just a personal comment as an EMT that is very interested in the actions of the Education Committee, because I know I've been reassured, but I'm very worried about transitional courses and being able to get my transitional course. I'd like to applaud Jody's actions today in stating that he's going to try and get more webcasts, more ability for people to see what's happening at the interim meetings that the Education Committee is doing. And I also want to thank you for your efforts to revisit the issue of the CCMP. I know nothing about that. I always recertify just using CE. But I think it's important for the largest number of stakeholders to have input into the eventual product that the Education Committee produces, because this is a stakeholder-driven process, and in fact, many's the time that we've looked at this process and gotten feedback that it is because of the stakeholder involvement that we can be successful as a group. So I would most respectfully suggest that actual votes that occur on the Education Committee to move things forward actually occur at the GETAC education meeting during this week. I mean, I was at the last interim committee hearing, and there were only 5 or 6 people at the time that I was there, and there were like 50 here. So it seems to me that that's an appropriate thing to do. Thank you, guys.
Thank you, GK. Public comment, general public comment is still open if anyone else would like to address the council.
I have 2 things. I'm coming as just a regular person. I had a question on your medical director letter. I know the importance of trying to get the C-suite hospitals personnel to understand your need for information. What is your distribution plan for that letter? I know you talked about the medical board, but do you have a plan that will also go out to the Texas Medical Association and the TCEP and Texas Hospital Association, Texas Neurological Association, American College of Cardiology, and you know, just all the different flavors of disciplines out there? Because I think it's important that they all understand that EMS needs information and to be able to close the loop in patient care. So that just would reinforce it if you were to use some kind of distribution plan like that. It's just a thought. Then because my understanding is it was for the medic or the RACs to give it out to the hospitals, but if you also disseminate it downward too, might be a thought. Then the other thing is, it is going to be EMS week, and I just wanted to share this with you. I did it last year, shared it with you, and this is this year's version. But it's an EMS newsletter, and the thought was to be able to teach physicians that are in the hospital that are beyond just the ED physicians, but just, you know, the regular physicians that are in the hospital, what EMS is about. The first cover on this is we interviewed EMS medical directors and an EMS director, and we said, what are the 5 things that you'd like to tell physicians in hospitals? And the topics were the scope of practice, drug shortages, rural EMS, technology and training, and communication and feedback. Then on the inside, we tried to show that EMS is part of something bigger, which is your trauma system, your emergency healthcare system, and we have trauma service area information, the map of all the racks. We have our CAT rack information, what is it, what does it do, and then we have our Safe Start program, which is where the medics will come in and everyone will be quiet. The nurse will identify who's taking the report, and then they'll listen to what the medic has to say. On the back, we interviewed RAC committee members that work in our healthcare system and asked them, you know, what's the benefit of actually participating in RAC or in the CAT RAC, and also, you know, what's the professional and personal benefit, and then also ask people to join. And then we have 3 things on how to celebrate EMS Week, and then contact information. This was something that we did so that we could educate our folks within the hospital, deeper down into the hospital and higher up into the hospital, because it is such a valuable organization and they don't understand. And they have no clue about EMS. Just, I'll share this with you if you're interested.
Okay,
Thanks.
sure. Thank you. General public comment is still open for anyone else that would like to address the council. One more time, would anyone else like to address the council under general public comment? Seeing none, I'll close the general public comment of the agenda. And want to review quickly the items, agenda items for next. There was an agenda item concerning vendors for, it was the DMV or the Joint Commission for the stroke comprehensive. I had that down. And then if it's not too late, recommendations on the medical board for medical directors from the Medical Directors Committee. And then I had down we needed to do it, actually this wasn't an agenda item, we just needed to adjust that information about the less than 15 years of age. And then we had the pediatric position paper, the 5 points about the non-ionizing radiation, and then I believe that was all that I had. Did I miss anything? Okay, I assume that lunch is ready? About what? 10 minutes. Okay. Well, I tell you what we'll do is, unless the council wants to convince me otherwise, we'll recess for 15 minutes. I'm sorry, go ahead. Oh, take it down. Okay, yeah, it's been a long morning. We'll recess for 15 minutes so we can take care of personal business and lunch, and then we'll reconvene in 15 minutes.
If you signed up for lunch, it'll be right out there, and we'll take care of payment out there too. And I know I've got your credit card. I love Jimmy Choo's. Did you know that?
She's already been to the mall.
Oh, I kind of.
I'm in email jail, and so it won't go through.
But as soon as she gets it, she'll